Okay, we're going to move to Martin O'Donnell, who he's local, but local. Martin is local, but in fact he's also global insofar as his work spans continents. He's not just focused on doing work in one place. But the interesting thing about Martin, I believe, is the fact that Martin endorses and has used a variety of different study designs. So he has experience of using observational designs, like, I guess, case controls studies, or longitudinal designs. And again, in my experience, the people that are the best trialists are often the ones who are or have conducted non-experimental studies, because they really understand both the limitations of observational studies and the merits and the advantages, and also the disadvantages of experimental design. So it's pretty unusual to see all of that combined in one individual, but Martin's going to share some of his insights into how you design trials in a clinical setting. Right.
Thanks, John. And thanks to Declan and Sandra for inviting me to present. So I guess, this talk could be 20 minutes, it could be 2 hours, 20 hours. The advantage of having a broad topic in a short period of time is that you can make excuses for why things weren't included, and you can grandstand and you can highlight areas that you think are important. But I am going to try and give an overview of all sort of trial designs. I'm involved in a number of randomized controlled trials, some of them industry, some of them not industry, some of them medicinal products, and some of them not. I guess there's been a lot of talk about Bradford Hill this morning, which is really important. When people do courses in clinical research and they talk about Bradford Hill, it's invariably in the context of observational research studies. And again, it's teaching people how observational research studies may fulfill the Bradford Hill criteria for causality. When in actual fact, the optimal study design to demonstrate or disprove causality is a randomized controlled trial, and particularly a definitive one. So again, the central tenets that have been discussed this morning and the importance of that contribution to this. Some argue that the most important contribution to clinical research has been randomization. And again, that the issue being that causality is when you take everything else away and you look at one individual factor, the independent contribution of that factor, does it change something? Does it alter the natural history something, or does it not? Randomization allows you to balance measured and, more importantly, unmeasured confounders between two groups. It's the beauty of something so simple, but you get the exclusion of those confounding factors, presuming that the randomization process is correct and presuming you have an adequate sample size to get balance. It all goes to the clinical research question, though. So frequently we get requests, John gets requests within our group, which is, what design should I have? Or more often it's, I want to do this design, rather than discussing what the optimal design is. And there's many considerations. There's the research question, there's pragmatism, there's where in the evolution of research people are. But it's a little bit like whenever you Google, what is the best laptop? There's no one answer. The issue is, what do you want? What do you want to achieve? Do you want a good screen? Do you want a good keyboard? Are you a programmer? Are you a gamer? Are you somebody who has it for different purposes? So the research question and the purpose of it, designs are tools, and you need different tools in different settings. Case control design is not necessarily worse than a prospective cohort study. It's contextual. It's like a lot of people feel that an MRI scan is the best test you can have. But for certain things, an ultrasound is better. For other things, clinical examination is better than an MRI scan. So again, it depends on what the question is. And within the question, it's the PICO, population, intervention, control or comparison, outcome and time. The phase of clinical trials I'm going to discuss, the design, methodologically and general principles, and then this kind of more recent concept of superiority versus non-inferiority concept. So it's like a matrix. These are aligned but exclusive concepts that all go into a clinical design. Most people in this audience are familiar with the development of drug products or medicinal or medical devices and medical technologies, and this is when you have a truly original, novel intervention that begins with early phase research, 0-1, and then through more the early phase of translational research, where you begin to get randomization, comparisons between two groups, into phase 2, where you're looking at surrogate outcome measures, to phase 3, where you're looking at outcome measures which are important clinical events, what some people term hard outcomes, like mortality, cardiovascular events, incidence of cancer, these types of outcomes where you're not being reassured by the effect of an intervention on a surrogate outcome, but you're demonstrating that that translates into a meaningful clinical benefit to people. The perspective is a little bit different as well. The earlier the phase, the more you optimize the probability that you're going to have a positive finding. As you move into phase 3 trials, it becomes more pragmatic, which is in real life circumstances. Even in circumstances such as concepts like intention to treat, where you actually disadvantage the intervention. If it proves to be effective, despite putting those methodological disadvantages against it, then it's worthy of investment. The methodological concepts I think the speaker following me will deal with in more detail, but again, the concepts of randomization, the different types of randomization, the things you can invest within them, some neat tricks around that while still maintaining the integrity of randomization. The concept of allocation concealment, and Joe articulated very nicely, and the distinction between blinding and allocation concealment. In our Masters in Clinical Research, I rabbit on about this repeatedly, and if you get that distinction, then you understand the process of the early phases of randomization. They're related, but they're different. Placebo control versus open label and the challenges that open label present to people, and particularly around conducting an unbiased trial when it's open label. And finally, the concept of run-in, where, and again, this is an emerging issue around the appropriateness and when run-in periods should be used, where you test the drug or you test placebo in the population before randomizing them to see whether they're suitable for the randomized controlled trial. The most obvious design, and the one that most people are familiar with, is the parallel design, where you randomize 2 or more groups to an intervention versus control. So this is a comparison. Throughout the course of the trial, people are maintained within the treatment group that they're allocated to. This is an example of a parallel randomized controlled trial evaluating the Mediterranean diet and 2 slight variations within the Mediterranean diet. The first definitive trial to show that this dietary pattern is associated with a lower risk of cardiovascular events in this population. A very simple design, a very elegant design, and the design that's the base model of randomized controlled trials that has changed clinical practice in almost all areas of clinical medicine. The crossover design is a neat design, and it's the type of design that many researchers keep saying to themselves, I should use this design more often because it's very efficient. So in the previous parallel randomized controlled trial, the comparison are 2 groups of people. In the crossover study, the comparison is between the same group of people, but the comparison is between 2 different periods. So one group begins on a treatment, the other group begins on the control, and then they cross over. So those that got the control arm get the intervention, and those that got the intervention get the control. Again, you balance the groups very efficiently, so it means that even if you've got small numbers, you have precise balance in confounders. The reason being it's the same group, because it's the comparison, it's the temporal difference. The problem with crossover trials, however, is that there are certain series of circumstances that need to be fulfilled. The disease generally needs to be a chronic condition with a stable natural history. So for example, you couldn't do a crossover design in people coming in with acute pneumonia, because how you were the first week after pneumonia is very different to how you were beyond the first week. So conditions like rheumatoid arthritis, osteoarthritis, pain conditions, where you have a stable natural history of the condition so that the 2-period comparisons are valid. The second criteria is that the intervention doesn't alter the natural history of the condition. So that when you intervene in the first period and then you stop the intervention, you have a washout period, that the effects of the intervention are completely gone, thereby making the comparison again valid. If you intervene with something which alters the natural history, so that in the second phase, if you receive the treatment in the first phase, you get ongoing benefit from that treatment, then the comparison becomes invalid. So it's a very elegant, efficient design, but it's only appropriate in a particular series of circumstances. The factorial design, again, another design that appeals to people enormously because you get 2 for the price of 1. Or maybe more exactly, you get 2 for the price of 1.3 because it's not exactly the same cost. This has been championed for many, many decades. And the origins of this were, for example, in preventative medicine. If you have an intervention that you reckon will prevent cardiovascular disease, you have another intervention that you reckon will prevent cancer. The 2 interventions don't interact with each other. They work completely differently, and the pathophysiology of the 2 diseases are completely different. You can conduct 2 trials within one. So you have 2 comparisons on either side. And this is a factorial design. Many statisticians, again, have argued that we should be doing more of these, and we should be doing 6 by 6 factorial designs. Bring all these trialists together and actually do interventions more efficiently. There are challenges with this particular type of design, however, and that is, 1, do the treatments interact? So clearly proving that they don't interfere with each other is the issue. Often these are now used at preventing one condition. It used to be that the interventions had to be completely separate, but there's no reason why that needs to be the case. You can have an additive effect. So for example, you could do a factorial with an antihypertensive, with a cholesterol-lowering agent, and then you're getting an additive benefit, and you're comparing the incidence of events within each of the cells. Interaction will be the second thing. So either they don't interfere with each other, you get an additive effect, or you get an interaction effect. And that's where the challenge enters in because of interpretation of the clinical research study around that. And particularly within that, it brings in issues around multiple testing additionally, where you have to adjust your alpha. But for the old traditional 2 interventions, 2 different outcomes, you've got 2 trials. And many people argue that this has been underused. The DASH sodium trial is a phase 2A randomized controlled trial that's largely the evidentiary underpinnings of the American Heart Association's guidelines on sodium restriction in the adult population within the US. And this demonstrates within one trial a crossover design and a factorial design. So within one trial, I'm sort of demonstrating how both can be done. And this was a trial where they randomized people to 2 periods and 3 periods of different interventions. You had the one particular dietary pattern, which is a traditional US versus the DASH diet, and then the factorial around sodium restriction at different levels. But it was temporal. They had sodium restriction in the same people ingesting different levels of sodium, and thereby demonstrating the blood pressure differences as these populations transition from high to intermediate to low sodium intake. But what you'll notice here on the graph, and the y-axis is blood pressure, the x is the transition from high to intermediate to low, that the slope of the blood pressure curve differs, suggesting that the effect of sodium restriction, depending on your underlying quality of diet, may be different. Okay, so again, it's important information, it's interpretation and analysis, however, for a true factorial comparison comes into it. But I think this exemplifies a clever, very neat design that optimizes methodological design to get the most efficient addressing of questions. But again, because of its complexity, it raises questions. Cluster randomized controlled trial. And again, this is largely around what is the research question that people are addressing. A wonderful example of this was conducted by the group in Galway with Andrew Murphy, John Newell, statistician, and I believe is used by the BMJ as an example of a trial on how to report a cluster randomized controlled trial. And in this type of design, the unit of randomization is not the individual. All of the designs I've discussed up to now have been where the unit of randomization is at an individual level. Somebody comes in, they get randomized to one or more interventions. In this design, the unit of randomization is a group, it's a cluster. So in this particular example, it's a general practice. So everybody within that practice, so it's almost like a hierarchical model, is approached for consent, but they're not randomized. The practice is randomized. And the reasons for that may be varied, but one of the reasons is where the intervention is a behavior. So in this case, the intervention is a complex intervention driven by the nurse practitioner on improving risk factor control for prevention of cardiovascular disease. Now you could do an individual level randomization, but because it's a behavior, it's a culture within the practice of optimizing and giving additional resources to risk factor modification, it's difficult to switch off between patients. How are you going to get the same nurse to do something completely different for two different patients? And secondarily, patients are in the waiting room chatting to each other, and one says, geez, I just had an hour there with, smoking and exercise, and the other person's going, I got like 5 minutes and I was handed a leaflet. So you get what's called contamination within that. So where you have interventions like that, and the second part of it is the perspective, which is if you invest in an intervention such as resourcing general practice with a specialist nurse practitioner in this area, will that manifest as improvement in health? So if the perspective is at the intervention being at a group or a cluster level, that's a key question to answer. So these interventions may be important at an individual level, but if they're pitched more efficiently at a group level, the benefits may not be realized. I think, Declan, one of your favorite designs? Yeah, definitely. Yeah. So again, there's this interface between what's clinical practice, what's observational research, and what's clinical trials. So the interrupted time series, where you have an intervention of proven efficacy or of questionable efficacy, but it's often at a systems level. You intervene and you show that before the intervention, the natural history of whatever the condition you were looking at is X, and subsequent to intervening, it's changed. The question that remains there is it the intervention or is it other factors? Because you can never bring an intervention in, particularly at systems level, in entire isolation. Behavior is beyond that change. From a pragmatic point of view, some people would say, I don't really care whether it's the intervention or the knock-on consequences of the intervention. But if you're rolling out an intervention where you have finite resources, and this is particularly applicable in low middle income countries, of something that may be proven, one of the approaches, you can't roll it out everywhere at the same time. Resources don't permit you to do it. So rather than leaving it to random chance, one can actually randomize the rollout and use that as an opportunity to study the benefits of this intervention within real life. So at the moment, we just got funded for a pilot phase study looking at the implementation of a stroke unit care in low middle income countries. This is a model of care that's of proven benefit in Western Europe and North America, but it requires resources. It requires occupational therapy, physiotherapy, speech and language. The question is, can you develop a sort of slimmed down model of this that's applicable and can be resourced in low middle income countries that improves outcomes? The advantage of a stepwise design is that every group participating gets the intervention. It's very hard in a study like that to ask people not to get the intervention but to be studied. If you do it with a randomized stepwise design, you get the internal comparison, but you also get the between group comparison additionally, because at some point in its evolution, half will have it and half won't. So it overcomes the concern around, say, temporal variations. Many conditions have actual, yearly variations, seasonal variations in their incidence. So if time is a factor, you need to control for it. A brief mention on superiority randomized controlled trials, which are the ones we conceptualize as being clinical trials, which is I have a new drug. Is this better than nothing, or is this better than existing therapy? When one is designing these studies, and particularly guiding the sample size, you come up with what's a minimally important difference. And that means what's an important difference that's worth investing in this technology, intervention? What's a meaningful difference that I can convince people to go on a certain diet? I can convince people to exercise more. I can convince health authorities to purchase something. And again, those different perspectives may be different. For an individual, any reduction may be important. For a funding health authority, they're likely going to need more than that. The importance with this is type 1 error, which is if you have a positive finding, this is better than that you're confident that that's true, which is where we set our tolerance for this at 0.05. Speaking of Miller-Fisher, as I understand it, it was at a cocktail party that Fisher decided to select this 1 in 20. But John, you can correct me when you come up afterwards. Because of superiority, the way you view this from a false negative perspective is slightly different. Yeah, it wouldn't be a good thing to miss something if it was there, but our primary issue here is to be confident that if it is there, we're going to find it. What's evolved over the last 20 years, and particularly over the last 10 years, is when effective therapies are identified, but those effective therapies have limitations, such as cost, such as side effects, such as inconvenience. And we look for newer therapies that we don't expect to work better, but that they will have advantages outside of efficacy, such as lower costs, such as lower side effects. Examples might be dose of radiotherapy. Can you gain the same clinical advantage with a lower dose, but you get the advantages of a lower side effect profile? You can give more people radiotherapy because you're truncating the period. That would be an example. The question then becomes, am I confident that I'm not forfeiting effectiveness, that I'm not replacing a therapy with something that preceded it, which was better? And the perspective here is largely on what is the minimally important non-difference? As in, am I confident that I'm not missing an important difference? And in this, the false negative becomes important. So people talk about 80% power. That reflects superiority trials. In non-inferiority trials, where you're more concerned about a false negative, then your power increases to 95%. So it approximates your type 1 error issue in superiority trials. This movement has kind of confused people, I think, and this is very much a field of research around non-inferiority thresholds, how you analyze non-inferiority studies, how you design them, when they're appropriate, when they're not appropriate. And this is a very active, engaging area of research, and it's particularly challenging when you've got therapies that are extremely effective. So, this is one of these slides where it's obviously a trick slide. And what it does is it gives perhaps the historical perspective on superiority versus non-inferiority. So to look at these two, which treatments are the same? And these are two trials comparing two different antithrombotic agents for the secondary prevention of ischemic stroke. So when you look at it, you look for the gap between the two Kaplan-Meier curves. And the one on the left, there looks like there's air. There looks like there may be a difference. The one on the right looks superimposed upon each other. This one concluded that there was no difference between the treatments. This is an older trial. It was a superiority trial. They failed to show superiority, so they concluded there was no difference. But failure to prove superiority isn't proof that there is no difference. There may be a difference within a smaller margin. This was one of the earlier non-inferiority studies, and despite the fact that these curves, you can almost not distinguish between them, the conclusion was that it was not non-inferior. And if you're like me, I absolutely hate double negatives. It really messes with my head. But the issue with this trial was the non-inferiority margin that was selected couldn't be achieved. So clinically, this is a trial where everybody has interpreted this clinically as being no difference, despite the fact the analysis, the p-value, failed to achieve that. So in close, causality is served by many masters, but although not in the Bradford Hill criteria, the tool of randomization and a randomized controlled trial feeds into causality optimally. The research question is absolutely everything. There are many ways of answering a clinical research question, but you have to be cognizant of the limitations and the rules that apply to designs, particularly crossover designs, factorial designs. There are other ones like quasi-factorial, there are partial factorial designs. But you need to understand the price that's paid for taking on those designs. And clinical research is always, or design is always this series of compromises. There is no perfect study, or at least there's very few. And the issue is, what can I get done? What can I answer validly? What is the population of interest? What's the natural history of this condition? How does the therapy work? Does it alter the natural history? Is it a behavior? Can you randomize at an individual level? Do you need to randomize at a group level? The phase of clinical trials, which is largely in the evolution, identification of therapies, and this emerging concept of superiority and non-inferiority, which is really important. We still see designs coming through in sample size calculations that are asking a non-inferiority question, but the sample size calculation is targeting a beta, which is more appropriate for a superiority study. The other part of this is, it's not an hour drop-in, which is the final plea. This isn't, we're going to drop into these guys, we're going to tell them what we want to do, we're going to punch in all the numbers, and then in an hour's time they're going to come back and tell us what we need to do. That might happen, but if that happens, chances are you've already got the design yourself. It does require thought. So one of the things that's important is think about the study many months before you begin it. And I know people are blue in the face from saying that, but it's terribly important because you begin with a certain design and you can end up, discovering many others. So you're confident when you're finished that you're doing the best design rather than the perfect one. Thanks.